physician assistant with Gardner-Webb University. Planning on doing an eye examination today. Is that okay if I proceed as a student? I'm working with Dr. Smith today. What's your name, date of birth?
Nolan.
Record. Get all that information.
96.
96, young. And so then you make sure the lighting's good, obviously. I would go ahead and wash my hands, carry on small talk, and then basically show professionalism throughout the exam. So, go ahead, Scott. You can read it for me.
So you're going to test the visual acuity, cranial nerve 2.
So, yeah, and so one of the things I want you guys to come familiar with is what you're actually testing when you test visual acuity, when you test ocular motor movements 3, 4, and 6. So you need to know those things. Your medicine makes no sense if you don't know what you're doing. If you're just doing something to be like, oh, I'm just doing it to do it, and yet maybe abnormal. What does abnormal mean? Okay? And so it's important to always, I'm a big stickler on that. If something happens, why does it happen? All right? So, anyway, so you really need to look at your card. Okay, this is a 14-inch card. So this will be a good one. It's a hole punch. Get a little string, take it to his chin, and that'd be about 14 inches. Cover, and so first off, you want to say, do you wear corrective lenses?
No.
So then we don't have to worry about testing with and without corrective lenses, okay? So that's just something you can voice in the formative. Even if they wear corrective lenses or glasses, you only have to check one, okay? And then just voice that you would check it with both. So cover your right eye. Read the smallest line you can see from left to right.
1, 2, 8, 7, 3, 9. All the way over.
So you can just read one. Okay, so he read, what did you read? Okay, 4, 2, 8, 7, 3, 9. Okay, so he read the small sign. The key here is to look and see what he is. I have students all the time that are like, good job. All right, read the next line, cover your other eye, you got to know what he's reading so you can give him a measurement. So he was 20/20. So now I would ask him to cover the other eye. Now this time I'm going to change it. So I ask him to read left to right so that he doesn't just typically say, remembering what he just read. Now we'll ask him to read right to left. So I'll hold it about 14 inches. Can you read from right to left? The smallest line you can see.
9, 3, 7, 8, 2, 4.
Okay, so that was the same line. So he has 20/20 vision. And now I would check it with both eyes. Okay, both eyes from 14 inches away. The key is to make sure you know where you're at. All right? So once I've checked visual acuity,
Yeah, so right after visual acuity, make sure you do it with and without corrective lenses, which he did. Inspect the eyebrows and eyelids, noting the symmetry, erythema, or any lesions.
okay, so make sure you voice what you're looking for. So I go ahead and put my gloves on at this time to protect the patient. And so I will look, you've got symmetrical eyebrows. His eyelashes, can you close your eyes? Okay, you can open. Look okay, I don't see abnormal growths, extra eyelashes, or anything like that. No infestations that I can see. No signs of inflammation, any exudate on the eyelashes like an anterior blepharitis or anything like that. So that looks normal to me.
Inspect and palpate the lacrimal apparatus.
So remember, the lacrimal gland is right under here, kind of centrally located. So you want to push up, make sure no swelling, inflammation, or tenderness. And then you can palpate the lacrimal sac right here in the center to make sure you don't feel any swelling or tenderness. And those feel normal.
Inspect the conjunctivae, noting any lesions or injection.
Lesions, injections, inflammation, anything like that. So here, guys, what's the two types of conjunctiva?
Bulbar.
Bulbar and
They said, yeah,
palpebral. Okay? So remember, palpebral is down here connecting to the actual inferior eyelid. And actually, the superior eyelid as well, but I'm not going to worry about flipping his eyelid out unless he has a problem. So this would be sufficient for palpebral. So put your head down so you can see. And now what I'm going to do now is look at his bulbar conjunctiva. So I ask him to look up, look right, look left, look down, look down, look right, look left. And so I'm viewing all of that to make sure I don't see anything concerning, okay? While I was doing that, I also, to save time on your exam, say I'm going to visualize the sclera as well. So when I was looking at his sclera, same thing, having him look up and down all around to make sure I don't see any discoloration to it. Remember the muddy brown sclera that you'll see sometimes in African Americans is a benign normal variant, okay? But you can do the conjunctiva and the sclera at the same time, okay?
So combining those two, inspect the pupils,
Yeah.
noticing the size and the symmetry.
So when we look, you want to make sure both of them are about the same size they are. You want to make sure that the shape is regular, they're circular, okay, they're not irregular. And right now his is somewhat constricted, okay? And so sometimes patients with lots of light, it will constrict. We turn off the light, obviously dilate. If they don't dilate very well, then you might ask yourself what type of medications or stuff they may be on, okay? Remember, opiates cause pinpoint pupils. So if a patient comes in on pain medications, you cut off the light, or they come in, they may have pinpoint pupils, you cut off the light, try to do a fundoscopic exam, you can't see nothing. It's because their medications are causing that effect, okay? And so you want to know what medicines the person's on, because that can affect the ability for the pupil to constrict or dilate, okay?
Uses oblique lighting to inspect the cornea.
Yeah, so you can do this with or without the light on. Sometimes you can see better with the light off. But you want to ask the patient to look straight ahead. So just look straight into those door hinges. And so what you want to do is kind of come in from the side. You're not going to see a lot here, guys. You're just looking for topography. And you want to make sure that the cornea is smooth. There's no concavity to it or any type of inundations or anything like that. And you need to come over here to the other side. Same thing. It's just kind of have that light where tangential lighting is shining, and that I can see a really smooth surface to the cornea. That's all we're looking for, okay?
Test direct and consensual light reaction.
So they call this a swing-in flashlight test, okay? And so what you want to do is swing in, swing out. We're looking for the afferent pathway to go back, and the efferent to come back and make the other eye do the same thing. So look straight at my nose. So when I come in, pupil should constrict. It does just a little bit. His pupils are already constricted pretty good. And then that one dilates, so I swing in again, but this time I'm looking at this eye to make sure it reacts to the light as well. Because the signal should go back, bounce back, and this light should constrict as well. Okay? And so now I'm going to do this eye. But here, constricts, I go out. I'm no longer looking at this eye. It's working. Now I'm going to look at this eye. Here, constricts, and then comes back. Okay? So what we're doing is just making sure both eyes, we call that the swinging flashlight test, okay? Did everybody see that? Yes?
Test accommodation by pupillary constriction upon convergence.
Yeah, so the thing here is it's accommodation. So watch my pen fall all the way in. What you'll notice, and sometimes it's hard to see, is when I go toward his nose, his pupil will constrict. You can really appreciate it when you come back out because the pupil will start to dilate again, okay? So in, pupil will constrict. You don't have to have a lot of pupil in, and as he comes back out, notice that his pupils did get a little bit larger, okay, but they should constrict.
Test EOM in the 6th cardinal position of
So this is your letter H, and so hold your head still, make your eyes track my pen everywhere it goes. So we just want to go to maximum here. We don't want him to move his head, and if you go too far out, you can actually cause a maximal point nystagmus, which is benign, but their eyes trying to track and they just can't go any further. It'll move. So watch this as far as you can over, and then go up, go down. Notice I'm not in the big path here. I'm just making sure all these extraocular motions are intact. This is cranial nerves 3 and 4 and 6. Okay? And often what I'll do is my big H, and then I'll do my accommodation. Okay?
Test visual fields for confrontation.
So here's where a lot of students pay attention, pay attention, pay attention, pay attention, pay attention. So what we're going to do is be kind of close to Nolan. Okay? You don't have to grab the head like this, but I'm going to so I can have him where I want to. So I want you to look straight at my nose the whole time. Cover your right eye. I'm covering the opposite eye that he's covered because I'm not asking this eye to compare to this eye for this peripheral field. That would be fair, right? So eye to eye for this peripheral field. Everybody see that? So it's going to be my opposite eye. Cover. What I want to do is get eye level with him. I want to put my hand in the air and I want to ask Nolan, can you see my hand? Looking straight at me. Can you see it now?
No.
So what I'm going to do is look straight at Nolan. He's going to look straight at me and he's going to tell me when he sees my hand.
No.
Okay, that's about where I see it. Notice I'm moving slow. I'm not doing this because then where'd you pick it up? You have no clue, okay? So now, there's 4 quadrants to every eye, right? Right upper, left upper, right lower, left lower. So now we're going to do low. Can you see my hand?
No.
So as I move it in, you tell me when you can see it.
No.
I can too. Now, Nolan stays. Nolan stays. I take this hand and cover this eye to get this side. Can you see my hand?
No.
So as I come across slowly, he's going to tell me when he picks it up.
No.
So did I. Now I'll come down low. Can you see my hand?
No.
As I come up slowly, tell me when you can see it.
No.
Okay, so can I. That's peripheral builds for one eye. Then you switch and do the other side. Okay? Does everybody, that makes sense? You got to know at that starting position that neither one of you can see it because you don't have anything to compare it to if one of you can see it already. Okay? And it's eye to eye. My opposite eye to his eye because we're testing that lateral field. Okay?
Performs cover uncover test.
So, say I thought that this eye was turning inward. And I look at Nolan and I say, okay, I'm going to cover Nolan's strong eye. What's that going to make this eye do? Work harder or work less?
Work harder.
Work harder. So that eye is going to pull itself out. And then when I let this eye come back in and work, this eye is going to get lazy again. Okay? So typically what you do is you cover the strong eye and then you let that come over. It'll move over, and then when you move it, it'll go back. Okay?
So now you'll move on to the fundoscopic exam. So you'll verbalize, I would dim the room light before the fundoscopic exam.
So yeah, it's going to be a little bit hard with those glasses over there, but I'll show you anyway. You want your room to be dark except for just a crack in the door so you don't stumble in the room. Okay? So when you do this on skills day, open that much is sufficient with the light off. Okay? And so in just a minute, Austin or Sid, I'll have you turn the light off, but just wait a second. So how do you work your fundoscope? So the number one thing you do is you want to turn it on. Okay? And so I turned it on. So I want to hold this up to my hand, and I want to see which aperture I want to use. So that's blue. I don't want that. This is white. That's about a good size. That's a little bigger. So let's go, if you got this one kind of straight up at 12 o'clock. So your dim button on these is here, and you got to hold it till it dims. So notice that dimmed it. If I twist, and you just got to let it go when you're ready. So I want it slightly dimmed. Alright, so remember we're looking at the far structures is what we're concerned about, not the close structures. Close structures, we try to read our palm print, okay? And I really don't need my gloves after I get through inspecting the eyes, so go ahead and take those gloves off. I just didn't. I should have. So I want to find something about 10 foot away. So I'm going to look over here at the hand sanitizer box. I'm going to put my diopter at 0. So it's at 0. It'll be white. And so now I'm going to look at this Purell sanitizer box until it comes into focus, about 8 to 10 foot away. Oops, that's going the wrong way. It's getting worse. Okay, I can focus on it pretty good about right there, okay? And so as I get older, the worse I'm getting, okay? And so what I do is I got my focus. So now cut the light off, Sid. So Nolan, what I want you to do is look straight over my shoulder at this sign that says caution glass door. Just stay focused there, don't pay attention to what I'm doing. So what you have to do, guys, is you got to do left eye to left eye, right eye to right eye. Because you're going to be weak in one eye, number one, so you got to know this rule. Because if I don't, Nolan probably would not feel very comfortable if I try to take my right eye, say I'm strong in it, to look at his left eye. Because when I do that, guess what's going to happen with me and Nolan? We might meet. He ain't going to be happy, I ain't going to be happy. Okay? So, you can't do that. So it's left eye to left eye, right eye to right eye. You can practice with your strongest eye, but then you got to be able to do both sides. Okay? So, what I'm going to do first is 15-degree angle. So I'm just slightly off center. Nolan's looking over my shoulder. He stays focused straight away. Keys here I want you to watch is how close I get to the patient. If you're back here, guys, I'm going to count you off every time because you are not seeing anything. You're not close enough. We're looking through the pupil to the back of the eye. You have to be close. I'm talking like 2 inches, almost touching your hand. I make a C, kind of like Mike Tyson's tattoo is the way I think of it. So here, I get my light reflex from about 18 inches away. And then I'm just gonna go track in, 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 and see how close I am to Nolan? And I can see his vessels. And I can slightly move into all the quadrants. And I can see his optic disc right there, okay? And at the very end, you're going, while you're still in, you're gonna tell Nolan, you're in here, look into the light. And then you pull back. When you look in the light, you're trying to see the macular fovea. I've been practicing 8 years, guys. I maybe seen that bad boy 1 or 2 times. It's hard to do with these because your eye's not really dilated with the medicine or anything. But that's how it works. So I'm gonna cut the light off to spare him. So remember, see, straight ahead, red reflex, follow it in, keep steady, keep steady, keep steady, keep steady, to almost where you touch your hand. Look into all the quadrants really slowly, look into the light, and then you're done. Okay, and then you switch sides, and it's going to be the opposite eye this time. Okay, turn on the light. Any questions? Practice, practice, practice. All right, I'll come around and answer questions.